Start. Welcome back, guys. Okay, welcome back, guys. In the previous class, we have discussed about the basics. Now, in this class, let's continue with the glomerular filtration. So, in the previous class, we have completed till here. Now, let's continue about the glomerular filtration. Okay. Now, see, in previous class, we have discussed that the glomerular filtration barrier is actually made up of three components. What are the three components? First one is endothelial layer, which is present in the glomerular capillaries. Second one is the glomerular basement membrane. And third layer is the podocyte layer. So there are three layers in the glomerular filtration barrier. Now, I'm telling you that this glomerular filtration barrier, please note here, filtration barrier. Filtration barrier. Now this filtration barrier is actually a size barrier as well as charge barrier. Okay, the glomerular filtration barrier is size barrier and charge barrier. Now why I'm saying it as a size and charge barrier? Because this glomerular filtration barrier, it only allows certain size particles to filter. Okay, so not all whatever is coming to the glomerular capillaries is getting filtered. Not everything is getting filtered. Only a particle size of 4 to 8 nanometers. Only this size particles are filtered, and size greater than 8 nanometers, they are not filtered. Okay. If anything which is greater than 8 nanometers in size, so those substances are not filtered into Bowman's capsule. Now why we are calling it as a charge barrier then? Okay, size barrier I have explained you, only it allows certain size substances to filter. Now why we are calling it as a charge barrier? It's because it only allows positive charge and neutral charge substances to filter. Negative charged substances are not filtered. Okay, negative charge substances are not filtered. Why? You can ask me, sir, why negative charge substances are not getting filtered? Because, very important point, because glomerular basement membrane is also having negative charge. See, the glomerular basement membrane. Let me show you here, guys. See, the entire glomerular basement membrane. The glomerular basement membrane is also having negative charge. And if anything, if any substance is also having negative charge will repel with the negative charge so that it won't be filtered. So, glomerular filtration barrier is charge dependent barrier. It doesn't allow negative charge substances to filter because glomerular basement membrane is also having negativity. Negative charge will repel the negative charges, so filtration will not happen. Can you give me one example? If anyone can give me one example why negative charge substances, like example, I just want that example. Which substances are not filtered? Which negative charge substances are not filtered? See, example here is albumin. Okay. Now, albumin, it's very small substance. We all know albumin is a plasma protein. Okay, albumin is a plasma protein. Now, it's a very small substance. Okay, it's very small. Then why it is not getting filtered? It's because though it is small, it is having albumin as a molecule, it's having negative charge. If it's having negative charge, what will happen? it is repelled away. Why albumin is not seen in urine in a normal person is because albumin is something having negative charge. So glomerular basement membrane is also having negative charge. So what will happen? Repulsion will occur. Okay, so that's a very important example which you need to know. Why albumin is not filtered? Because albumin is a negatively charged substance. Now after this, let's discuss about why glomerular basement membrane is having negative charge. Why it is having negative charge? Now, I have in a single line I have just said you glomerular basement membrane is negatively charged. Why? The question is why? Because it's having certain important substances which are negative in nature. The glomerular basement membrane is negative because of presence of glycoproteins, heparan sulfate and sialoproteins. Okay, so very important point, the glomerular basement membrane is the negative in charge or a negative in nature because of presence of certain substances within it. The substances like glycoproteins, heparan sulfate and sialoproteins. This is a very important MCQ. Okay, heparan sulfate is a negatively charged substance. That's why it's giving the negativity to the glomerular basement membrane. Now, after this, let's talk about the substances which are filtered and substances which are not filtered. Substances, first talk about substances which are not filtered. The substances which are not filtered. Now, blood is coming via afferent arterioles. See, let me show you. Okay, let me show you with a different color. Here, take it as a afferent arteriole. Here are the glomerular capillaries. Okay, these are the glomerular capillaries, and this is the efferent arteriole. This is afferent arteriole. Here it is efferent arteriole. These are glomerular capillaries. So here is our Bowman's capsule, the first part of the nephron. Now please see here, blood is coming via afferent arterioles. Blood is coming via afferent arterioles. Now filtration will happen here. Now why filtration will happen? What are the pressures involved in filtration? We will discuss in a minute. But filtration is happening here. Now which substances are filtered and which substances are not filtered? Now first the topic is which substances are not filtered. Now just I am asking you, RBC is filtered, WBCs are filtered, plasma proteins will they filter, platelets will they filter, glucose will it filter? See, the substances which are not filtered include RBCs. Your RBCs are never going to be filtered into your nephrons. RBCs are not filtered. Even WBCs are not filtered. Platelets are not filtered. Plasma proteins, PP for plasma proteins are not filtered, and clotting factors. So all these substances, very important, never forget RBC, WBC, platelets, plasma proteins and clotting factors. These substances in a healthy individual will never be filtered. They will never be filtered. Okay. For example, imagine if RBCs are filtering into the nephrons, that RBCs are eventually going to come up in the urine. That will cause hematuria, which is absolutely pathological. Okay. So RBCs, WBCs, platelets, plasma proteins, they are very important substances for the body. They are not supposed to be going out in the urine. So they are not filtered. Then what is filtered, sir? What's filtered is the liquid component or the fluid component, that is plasma. What is filtered is plasma is freely filtered. Okay. So plasma is filtered. Okay. Okay. Plasma is filtered. Now I will ask you one question. Just tell me. See, here albumin is coming. Albumin is what? Albumin is, let me draw you here these molecules, albumin. Okay, not this much big molecules. Yeah, let me show you with a different color. See, these blue small molecules, let's take them as albumin molecules. Now albumin is very small. Okay, albumin is very small. It's coming. Its size is almost somewhere around 4 to 5 nanometers. Will it be filtered? No, albumin is not filtered. Please don't forget. Albumin, though it is a very small molecule, is not filtered. Why? Because albumin is negatively charged, as well as, see, albumin is a negatively charged molecule, as well as we know glomerular basement membrane. Okay, glomerular filtration barrier, because of the heparan sulfate, glycoproteins, it's also having negative charge. So negative charge will repel negative charge, so there won't be any filtration. Now, my question to you is, guys, will glucose be filtered or not? Okay, glucose and amino acids. Amino acids, will they be filtered or not? My question to you. You just think logically. Amino acids and glucose, will they be ever filtered into nephrons? Filtered or not? Just tell me. I'm giving you time. You think and answer. Glucose, will it be filtered or not from here? My question is, glucose is coming to the nephron. Glucose molecules, will they be filtered or not? I'm seeing the chat box. You can be interactive with me. Will they be filtered or not? Anyone? Even if you don't know, just try to answer. Like, there's nothing wrong if you answer it wrong. Yes, excellent. Glucose will be absolutely filtered. Glucose and amino acids both are filtered. Okay, so both the substances, glucose and amino acids, both are filtered. Now you will think like this. As a normal first year students, they will think like, glucose is very important for the body, amino acid is very important for the body. If they are filtered, then glucose urea will happen, amino acid urea will happen. See, they are filtered, but 100% all glucose molecules and all the amino acid molecules will be completely reabsorbed back in the PCT. See, after Bowman's capsule, what you will be having, guys? After Bowman's capsule, you are having proximal convoluted tubule. Okay, after Bowman's capsule, the first part of nephron, that's a proximal convoluted tubule. See, amino acids are coming here, even glucose is coming here, but 100% of the glucose and 100% of the amino acids will be reabsorbed back in the PCT. Okay, now tell me, glucose and amino acids, are they filtered or not? Yes, they are filtered. RBC, platelets, plasma proteins, RBC, WBC, platelets, plasma proteins and clotting factors, will they be filtered or not? They are not filtered. Okay, now after this, let's talk about something very important, which is called as slit diaphragm. Slit diaphragm. Now, a very important pathological correlation is there here. Now, you should know where exactly is this slit diaphragm located. Guys, here I am zooming up. Okay. Now, you just tell me, sir, what is this point which I am showing with the red color? So, what are these cells? They are endothelial cells of the glomerular capillaries. Okay, they are having the spaces. See, these are the fenestrations. Okay, for leaking of the plasma. They are glomerular capillary endothelial cells. Now, down to glomerular capillary endothelial cells, which I am showing you in green color. What is this layer? This layer is the glomerular basement membrane, sir. GBM, glomerular basement membrane, which is having negative charge. That's the second layer. Now, the third layer, which I am showing you with the blue color. See, what is this cells? What are these cells? These cells, which I am just highlighting with the blue color, they are called as the podocyte cells. Okay, podocyte cells are the visceral cells. Now, please be very attentive. Please have a keen eye. Sir, here, are you able to appreciate this linkage proteins? Are there not this one protein which is present in between the podocytic foot processes? It's there. See, completely it's there. Now, it's also acting as a barrier for the filtration of substances. It's acting as a barrier or not? A substance X should have to move from here into the Bowman's capsule. Okay, here is the lumen. Here is the lumen of the blood vessel or the glomerular capillary. RBC, WBC, platelets, plasma, clotting factors, everything. Okay, everything is here. Now, all those substances have to leak into the Bowman's capsule. So, what I am trying to put into your mind is, see, there is a very important protein or there is a very important structure called as slit diaphragm. That slit diaphragm is present in between the podocytic foot processes. Now, why we are discussing this is because, see, that slit diaphragm is something made up of three important proteins. The three important proteins which are making the slit diaphragm includes, the first protein is called as podosin, second protein is called as nephrin, and the third protein is called as alpha actinin 4. So these are the three important proteins which are forming a slit diaphragm. Now, why we are discussing this is because, see, there are conditions where podosin is affected, there are conditions where nephrin is affected, and conditions where alpha actinin 4 will be affected. Now, you just think logically and tell me, now if there is any damage to slit diaphragm, if there is any damage to slit diaphragm, will that cause proteinuria or not? Normally, proteins are not filtered. Plasma proteins are not filtered. Plasma proteins like albumins, globulins, fibrinogen, clotting factors, they are not filtered. But whenever there is a damage to slit diaphragm, that will cause leakage of plasma proteins into urine. So that's called as proteinuria. Okay. Now let's see what is the important pathological correlation. Okay. Now tell me, you have to, if you are really good, you just try to answer if you know. First, let's talk about nephrin. Okay. So nephrin is an important protein which is a component of slit diaphragm. Now nephrin is coded by, nephrin, it's coded by which gene, anyone knows? Nephrin is coded by NPHS1 gene. Very, very important MCQ from the patho. Now nephrin is something coded by a gene called as NPHS1. Okay. Now whenever there is a mutation, okay, mutation of this NPHS1, MUTAI1. So whenever there is a mutation of NPHS1, automatically nephrin will be affected. Now whenever nephrin is affected, that will cause leakage of the protein into the urine. So much and so much of protein is getting leaked into the urine. That will cause proteinuria. How much proteinuria, sir? Lots and lots of protein is going out. So if the proteinuria is greater than 3.5 gram per day, so in a day, okay, in a day, if this much amount of protein loss is there, okay, usually a very little amount of proteins called as a Tom Horsfall proteins, and usually a very little amount of proteins are leaking in the urine every day in you and me, in a healthy person also, there will be little bit proteinuria. But if an individual, if he loses more than 3.5 grams of protein per day, then we have to call it as a syndrome. Can anyone name that syndrome? Guys, I'm asking you. Excellent, excellent, Kong, whoever it is. Now, if there is a loss of more than this much amount of protein, that's called as nephrotic syndrome. Now, so defect in nephrin will cause nephrotic syndrome. Now comes the question. There are different types of nephrotic syndrome. Okay, nephrotic syndrome is not a one disorder. There are many diseases which are coming. Okay, nephrotic syndrome is a spectrum. There are many diseases which are coming under this nephrotic syndromes. So can you tell me, defect in nephrin will cause which type of nephrotic syndrome? Anyone? Defect in nephrin will cause which type of nephrotic syndrome? Not minimal, not minimal. Definitely this is not minimal. Okay, let me write it here. Congenital means by birth itself. Congenital nephrotic syndrome, that is Finnish type. Finnish type. Okay, so very, very important MCQ. Finnish type of nephrotic syndrome or congenital nephrotic syndrome. Congenital nephrotic syndrome which is steroid sensitive. Steroid sensitive. Okay, this is very, very important point. Now this type of nephrotic syndrome is steroid sensitive, which means with the steroids you can treat this condition better. Okay, so very important point is nephrin. It's a part of slit diaphragm. It is coded by NPHS1 gene. Mutation will cause congenital nephrotic syndrome of Finnish type. It can be easily treated with steroids. Now, let's talk about podocin. Now, podocin, it's coded by NPHS2 gene, NPHS2. Now, whenever there is a mutation of NPHS2, then podocin will be affected. Now, that will also cause proteinuria, nephrotic range proteinuria. More than 3.5 grams of protein is losing in 24 hours. Now, it will cause which type of nephrotic syndrome? The nephrotic syndrome, here it's called as steroid resistant nephrotic syndrome. Okay, steroid resistant nephrotic syndrome of childhood onset. Okay, just simple. It's a steroid resistant nephrotic syndrome of childhood onset is seen with the mutation of NPHS2, which is coding the podocin. Now, last one, that is alpha actinin 4. Alpha actinin 4. Now, whenever this protein is affected, okay, here genes are not that much important. Now, whenever this alpha actinin 4 is affected, it will cause also protein loss, nephrotic range proteinuria, nephrotic syndrome. But which type of nephrotic syndrome? It is called as autosomal dominant focal segmental glomerulosclerosis. Let me write it down here. Focal segmental glomerulosclerosis. See, focal segmental glomerulosclerosis is the type of nephrotic syndrome. It's a type of nephrotic syndrome because, like, there is so much amount of proteinuria. Why I am saying it as a nephrotic syndrome? Why? Because lots and lots of protein is getting lost. More than 3.5 grams of protein is getting lost. It's because of damage to which protein? Alpha actinin 4. Okay, alpha actinin 4. Now, after seeing this patho link, now let's see why actually filtration will happen. First of all, see, blood is coming via the afferent arteriole. Everyone knows blood is coming to the glomerulus via afferent arteriole. Now, here are the glomerular capillaries, and here is the efferent arteriole. Efferent arteriole. Now, what do we have here? These are the glomerular capillaries. Okay, let me show glomerular capillaries in a simple way. Okay, one capillary I am showing you. Now, my question is, why filtration is happening? First of all, why the plasma is moving from the glomerular capillary into the Bowman's capsule? Why it is moving? What are the pressures involved here? Now, to understand this, you should know certain terminologies first of all. Now, what are those terminologies? First of all, hydrostatic pressure. Hydrostatic pressure. See, wherever, whenever you take a fluid, it will be having a property called as hydrostatic pressure. Hydro means water, static. Whenever you keep water in one place, static, without moving, it will have a pressure, hydrostatic pressure. Now, to understand this, see, let's take a glass tumbler. Okay, glass tumbler, or just take aquarium. In your homes, you will be having the glass tank, right? Aquarium. Now, fill it with water. Okay, you have filled it with water without keeping any fishes. You just kept water here. Okay, now this water in this tumbler, will it exert any pressure on the wall? Now, water here, water molecules, will they exert pressure on the wall or not? Yes, they will exert pressure. All the time this water, whatever is there in this tumbler, it wants to come out. It all the time wants to come out with the pressure called as a hydrostatic pressure. Now, if you want to practically see it, just go and drill a small hole, just put a small hole, immediately water is coming out. Now, why? It's because of the hydrostatic pressure. Okay, so sorry. So, water or this fluids will have hydrostatic pressure. Now, based on the concept what I have taught you, blood is coming or not? Yes, blood is coming to the glomerular capillaries. Blood is coming to the glomerular capillaries. Now, here in this blood, plasma is there or not? Yes, sir, plasma is there. That's the water component or the liquid component. Okay, fluid component is there, that's a plasma. Now, will this plasma also have hydrostatic pressure or not? Yes, hydrostatic pressure is there. So, I am just showing you the hydrostatic pressure with the symbol P. So, hydrostatic pressure in the glomerular capillary, C for capillary. So, the hydrostatic pressure, how much hydrostatic pressure will be there? Anyone knows? 60 mmHg. The hydrostatic pressure in the glomerular capillaries because of the plasma is 60 mmHg. Now, this hydrostatic pressure is a positive force or negative force for glomerular filtration? It's a positive force, okay? It's a positive force. Why it is called as a positive force? Why? Because it is favoring glomerular filtration. All the water molecules, all the plasma molecules here, they want to come out of the blood vessel. Because of the hydrostatic force, they want to come out of the blood vessel. Now, in the blood vessel, is there is any other force? Yes, there is one more force is there. Now, what is that force called as? Osmotic pressure. Osmotic pressure. Can you tell me what is this osmotic pressure and why this osmotic pressure is because of osmotic pressure? Why osmotic pressure is there and what exactly is this osmotic pressure? I just want you to answer, guys. Yes, it's because of a protein. It's because of the proteins. Which protein? Can you name me? Which protein? Albumin. Okay, it's because of the albumin. See, guys. Here, albumin is there or not? Yes, in the glomerular capillaries, albumin is there. There is no doubt albumin is there. Okay. Now, try to understand for your entire life. Try to understand like this. These protein molecules, these albumin molecules, they are just like a sponge pieces. Okay, just take them as a sponge pieces. Imagine there was this one pipe with the water flowing. Okay, water flowing. Now, whenever you dip some sponge pieces, what those sponge pieces will do? Sponge pieces will try to absorb the water. Sponge pieces, whenever you dip a sponge piece, it will absorb all the water or it tries to keep the water with itself. So, same albumin molecules will also behave like that only. Okay. Now, albumin molecules, here they are present, right? Now, these albumin molecules are also acting like a sponge pieces. They want the plasma to be with them. Okay, they are not letting the plasma to move out of the blood vessel. Now, if someone comes to you and asks you, why in a normal blood vessel, okay, in normal blood vessel, why the blood is not coming out of the blood vessels? Why? Why? Because in your blood vessels, there are proteins called as albumin, and this albumin proteins, they are exerting certain pressure called as this osmotic pressure. Now, this osmotic pressure will keep the plasma within the blood vessel. It doesn't allow the plasma to leak out. Hydrostatic pressure, it wants the blood to go out. Osmotic pressure wants to keep the plasma within the blood vessel. So, tell me, osmotic pressure is a favoring force for glomerular filtration or it is against the glomerular filtration? It is against. So, it is opposing force. It is opposing force. Okay, it's opposing force. But hydrostatic pressure is a favoring force. Okay, now question. How much what is the osmotic pressure? The osmotic pressure, let me show you with the symbol pi. Okay, pi C for osmotic pressure in the glomerular capillary. So how much is it? It is 32 mmHg. 32 mmHg. Okay, so two pressures are completed. Now you have to know one more important pressure. The hydrostatic pressure. Again, see, if I am keeping P, that's the hydrostatic pressure. Hydrostatic pressure in the Bowman's capsule. Even in the Bowman's capsule, all the time, 24/7, even Bowman's capsule also, some fluid will be there, right? Yes, some fluid will be there. Now, here the fluid in the Bowman's capsule will all the time move towards the capillaries. See, whatever the fluid is there in the capillaries, see, imagine these are the glomerular capillaries. Now, whatever the fluid is there in the capillaries, it want to go into the Bowman's capsule because of the hydrostatic pressure. But same is also true opposite. Now, whatever the fluid is there in the Bowman's capsule, because of the hydrostatic pressure, it want to move in the opposite direction. Okay. So, hydrostatic pressure in the Bowman's capsule, very little amount of fluid is there. So, little pressure. So, how much? 18 mmHg. Now, important point, I have just discussed with you three important pressures. Hydrostatic pressure in the Bowman's capsule, hydrostatic pressure in the capillary, osmotic pressure in the capillaries. Now, important point is, see, question is this 18 mmHg, the hydrostatic pressure in the Bowman's capsule, the hydrostatic pressure in the Bowman's capsule, is it a favoring force or opposing force? Is it a favoring force or opposing force? It is actually an opposing force. With 18 mmHg pressure, it's a hydrostatic pressure, right? It is opposing the glomerular filtration. See, hydrostatic pressure from capillaries, fluid want to go down into the Bowman's capsule, fluid want to come out, but from the Bowman's capsule with 18 mmHg pressure, it is opposing, okay? So, this hydrostatic pressure in the Bowman's capsule is a opposing force. Now, after seeing this, let's talk about the net filtration pressure. Will the filtration happen or not? If happens, why it is happening? Now, let's talk. Net filtration pressure. Now, this net filtration pressure, the formula is favoring forces. Guys, I'm having runny nose, sorry. Sorry for the inconvenience. Favoring forces minus opposing force. Okay, favoring forces minus opposing forces. Now, what are the favoring forces? The favoring forces is hydrostatic pressure in the Bowman's capsule minus, what are the opposing forces? Opposing forces are osmotic pressure in the capillary along with hydrostatic pressure in the Bowman's capsule. So, 60 minus 32 plus 18. Now, 60 minus, what is 32 plus 18? 32 plus 18 is 50. So, 60 minus 50 is 10 mmHg. So, 10 mmHg. Now, the favoring forces are 60. So, with 60 mmHg pressure, filtration is favoring. What are the opposing pressures? Opposing pressures are 50 mmHg. Now, who is more, guys? Favoring forces are more. When compared to opposing forces, favoring forces are more. How much? How much more? 10 mmHg. Okay. So, they are greater by 10 mmHg. So, filtration will happen. So, if someone comes to you and asks you, with how much pressure difference glomerular filtration is happening, with a pressure difference of 10 mmHg. Okay, so this is the reason why glomerular filtration is happening. More pressure is there in the glomerular capillaries. Hydrostatic pressures are more. So, filtration is happening. Okay, guys, do you understand the concept? Guys, do you understand the concept? If you have any doubt, you can all the time ask me. If you have any doubt, you can all the time ask me. Okay, now let's continue further. Now, in the previous class, we have already discussed. Sir, what is the glomerular filtration rate? GFR, glomerular filtration rate. Every minute, how much filtration is happening? Sir, the glomerular filtration rate is 125 ml. Glomerular filtration rate is 125 ml. Okay, filtration is happening every minute. 125 ml is happening. So, how we will calculate it? How to calculate GFR? Okay, now what is the gold standard agent? Please take down. These are the single liner points which you all the time you need to know. Okay, what are the gold standard agents? Gold standard agents for GFR estimation. Anyone knows? See, by injecting a substance into blood, we can calculate the GFR. How much is the GFR of the patient? there are three important substances, out of which one is considered as the gold standard. So gold standard agent, see someone is asking, if more proteins are filtered, will they not exert more filtration pressure? See, first of all, whoever is asking this question, first of all, proteins are not filtered. Proteins are not filtered. Who said? Like, no, I have already said you. RBC, WBC, platelets, plasma proteins, okay, and clotting factors, they are not filtered. Okay, they are not at all filtered. Plasma proteins, especially because of albumin, it will generate an osmotic pressure of 32 mmHg. The hydrostatic pressure is 60. The osmotic pressure in the glomerular capillaries is 32 mmHg. Okay, at the end of the day, favoring forces for glomerular filtration is more than the opposing forces. So with a pressure difference of 10 mmHg, glomerular filtration will happen. How much glomerular filtration will happen? Every minute 125 ml of plasma is leaking down. Every minute 125 ml of plasma is leaking down. So that is glomerular filtration rate. Okay, the rate with which glomerular filtration is happening, 125 ml. Now the gold standard agent is inulin. Okay, so inulin is the gold standard agent. It's not the inulin. Apart from inulin, okay, it's a gold standard. Apart from inulin, creatinine. Okay, so creatinine, as well as there is one more marker called as cystatin. Okay, cystatin C. So the three important markers are inulin, creatinine, and cystatin C. These are the markers with which you can estimate the GFR. The gold standard agent is inulin. Creatinine is the most commonly used for measurement of GFR, and the new marker which is available for GFR estimation is cystatin C. Now after seeing these markers, now let's go with the formula. How to calculate GFR. Let me write it down here. Formula for glomerular filtration rate. The formula is GFR is equal to UV by P. If you want to remember one formula from the entire renal physiology, at least remember this one thing. Okay, the formula is GFR. GFR, or the same formula can also be used for calculation of clearance. Okay, clearance of a substance. If someone comes to you and asks you, what is the clearance of a particular substance? Clearance or GFR, same formula. So what is the formula? UV by P. Now you will get it out. What is that U? U means, let me write down here. U. What is that U standing for? U for urinary concentration. Urinary concentration of a particular substance. Urinary concentration of a substance. Okay, of substance X, some substance they will particularly give you so and so substance, the concentration of so and so substance is this much in urine. So urinary concentration of that particular substance into V for volume of urine produced, how much ml of urine is getting produced. Okay, so urinary concentration of a substance into volume of urine produced by P for plasma concentration. Plasma concentration of that particular substance. Okay, they will say that particular substance. So what is the plasma concentration, what is the urinary concentration, and how much ml of urine is produced? If you know these three values, okay, if you know the plasma concentration of a substance, if you know the urinary concentration of the same substance, and if you know how much amount of urine produced, then you can estimate what is the GFR or clearance. So close your eyes and tell me, what is the formula for GFR estimation, or what is the formula for clearance of a substance? UV by P. Okay, UV by P. Now after this, let's talk about the changes in GFR. Changes in glomerular filtration rate. Normally, see, this is afferent arteriole which is bringing the blood to the nephron. These are the glomerular capillaries, and here is the efferent arteriole which is taking the blood again back to the systemic circulation. Now here is your Bowman's capsule, and the first part of nephron, this is the proximal convoluted tubule, this is the Bowman's capsule. Now my question is, this GFR will be altered with certain conditions. Normally here is the filtration happening, right? Now let's take an example of a condition where first condition, afferent arteriolar constriction. Okay. Now guys, I just want you to answer. If there is afferent arteriolar constriction, if the afferent arterioles, if they are constricted, means what happened to GFR? You think logically and tell me. Now if afferent arterioles are constricted, see here, this is how it will happen, this is how it will look. Afferent arteriole became very much smaller. These are the glomerular capillaries, and here is the normal efferent arteriole. Now afferent arteriole, it's constricted so much. So now what happened to GFR? Now GFR will be increased or GFR will be decreased? Now try to answer it. Yeah, less volume is coming, less volume of blood is coming to the glomerular capillaries. If less volume of blood is coming to the glomerular capillaries, what happened to GFR? GFR also decreases. So afferent arteriolar constriction will decrease the GFR. So very important point. Now afferent arteriolar constriction, afferent arterial constriction decreases the GFR. Now my question is, which substances will cause afferent arteriolar constriction? Substances which will cause afferent arteriolar constriction. Anyone? Anyone can say the substances which are causing afferent arteriolar constriction? Anyone? Yeah, Ismail, I am just asking you only. Okay, you tell me. Ismail, I am asking you, what are the substances which will cause afferent arteriolar constriction? No one? Afferent arteriolar constriction, just think logically. What are the substances which will cause vasoconstriction in your body? Sir, whenever the sympathetic activity is there, there will be release of adrenaline, norepinephrine. See, norepinephrine will cause afferent arterial constriction, right? Even it causes blood vessel constriction. Yes. So, norepinephrine and very important substance, adenosine. Okay, so norepinephrine and adenosine are the substances, okay, which will cause afferent arterial constriction, that will decreases the glomerular filtration rate. Now let's take one more condition where if there is afferent arteriolar dilation. Now if there is afferent arteriolar dilation, now what will happen to GFR? Just tell me. Afferent arteriole is dilated, efferent arteriole is normal. Now what happened to GFR? Here is a Bowman's capsule and here is a PCT. Now more amount of blood is coming. If more blood is coming, more blood will be there in the glomerular capillaries. More blood is there means more hydrostatic pressure. If more hydrostatic pressure means what will happen? Automatically GFR increases tremendously. So with afferent arteriolar dilation, note, with afferent arteriolar dilation, okay, dilation, GFR increases. Now my question is, what are the substances? The substances which will cause afferent arteriolar dilation. Anyone? It is the prostaglandins. Okay, so prostaglandins will cause afferent arteriolar dilation. Now after this, other scenario, let's don't change anything with the afferent arteriole now. Now afferent arteriole is normal. Glomerular capillaries are also normal. Now let's constrict the efferent arteriole. Now I am constricting the efferent arteriole. Efferent arteriole is constricted. Now what happens to the glomerular filtration rate? If efferent arteriolar constriction happens, means what happened to GFR? Think logically and tell me. It's very obvious, right? See, blood is coming. There is no doubt, blood is coming. Now blood is also coming to the glomerular capillaries. Okay, into the glomerular capillaries also blood is coming, but blood is not able to leave. Okay, blood is not able to leave. So what happens? All the blood is accumulating here. So more blood is getting accumulated here initially more blood is accumulating there. There is no way to go out. So there is crowding of the blood, which will cause increase in the pressures over there. So more GFR. So glomerular filtration, right? Initially GFR increases. Now if blood is accumulating here, there is no way to go out. Okay, very small way to go out. So what happens later? The blood which is coming also going to decrease. Okay, why? Because here more pressures are there. Blood is not going out. There is more pressure here. So initially GFR increases, but in the later stages. Okay. Initially GFR increases, but later what happened to GFR? GFR will go down, right? Because no blood is going out. So blood is accumulating there. So this accumulated blood over there will be an impediment, will be an obstruction. It acts as an obstruction. It's not letting the new blood to come. Not letting the new blood to come. So what happens? GFR decreases. So very important point is that, initially GFR increases, later GFR decreases. So this response is called as biphasic response. Okay. Now biphasic response is seen in which condition? Constriction of efferent arterioles. Now come with the example. Now what are the substances which, what are the example of substances which will cause efferent arteriolar constriction? Example is angiotensin 2. So angiotensin 2 will causes efferent arteriolar vasoconstriction, which decreases the GFR. Now final thing which I just don't want to draw it here, you just think logically and tell me. Now what happens if efferent arteriole, efferent, E for exit, if efferent arteriole is dilated, if it is dilated, what happened to GFR? Sir, if efferent arteriole, okay, let me show it here. Now afferent arteriole, glomerular capillaries. Now efferent arteriole is very much dilated. Now if efferent arteriole is very much dilated, now easily blood is leaving out, easily blood can move out. So blood is not staying in the capillaries, easily going. So what happens to the filtration? Now if blood is easily going out, filtration will not happen. So automatically GFR decreases. Efferent arteriolar vasodilation will decrease the GFR. Okay, so that's the one point. See, efferent arteriole dilated. Dilated means what happened to GFR? GFR decreases. Okay, that's a very important point which you need to know. Now after this, I will ask you, you just try to answer it. If you are really good, just try to answer it. If mesangial cells are contracted, means if the mesangial cells in the glomerulus, if it contracts, means what happened to GFR? We have seen afferent arteriolar vasodilation, afferent arteriolar vasoconstriction, efferent arteriolar vasodilation, efferent arteriolar vasoconstriction. How they will alter the course of GFR already we have discussed. But my question right now is that, will GFR be affected if there is mesangial cell contraction or mesangial cell relaxation? That's the question. Now, first of all, I just want to show you, first of all, what is this mesangial cell? Most of you students don't know. Guys, I'm just right now showing you Bowman's capsule, okay? Now, in the Bowman's capsule, I'm just showing you the cross section. Here are the glomerular capillaries. These are glomerular capillaries. Okay, these are many glomerular capillaries are there. Okay, now where is the plasma? So plasma is there inside the blood vessels. Plasma with RBC, WBC, platelets, glucose, amino acids, drugs, clotting factors are there inside the blood vessel. Now this is the Bowman's space. Okay, I am just showing in a different view. The substances are supposed to come out like this. Okay, the substances are supposed to leak out. Okay, now my question is, see, there are certain cells here in the space, in this Bowman space. There are certain connective tissue cells, okay, connective tissue fibers, okay, there are different types of cells which are present here. Now this area which I am just putting dots, okay, which I am highlighting right now with the dots, this area is called as the mesangium. Mesangium is the connective tissue. Okay, mesangium is the connective tissue here in the Bowman's capsule. Now there are certain cells called as a mesangial cells. Now where are these mesangial cells, sir? See, these mesangial cells, let me show you with a black color. Mesangial cells are something like this. Mesangial cells are present around the glomerular capillaries. Around the glomerular capillaries, there are these cells called as mesangial cells. Now these mesangial cells, they are having contractile proteins, so that they will contract sometime and they will relax sometime. Now based on their contraction and relaxation, GFR will be affected. Okay. Now tell me, if mesangial cells, if they are contracted, what happened to GFR? Just tell me. If they contract, capillaries will be collapsed. If the mesangial cells contract, even the capillaries will be closed or constricted. If capillaries are constricted, if glomerular capillaries, if they are constricted, what happened to the filtration? Automatically decreases. Why? Because the glomerular capillaries are constricted, no blood is passing through them. So mesangial cells, if they are contracted, means GFR decreases. The same is vice versa. If mesangial cells, if they are relaxed, what happened to GFR? GFR is going to increase. Now my question is, what are the substances, what are the chemical substances which will cause mesangial cell contraction, and what are the substances which will cause mesangial cell relaxation? See, mesangial cell contraction and mesangial cell relaxation, it's under the control of anyone? Substances which will cause mesangial cell contraction, anyone? I'm asking you. Miracle World and that, like, Roy. Just no need of big explanation. Just tell me, which substances will cause mesangial cell contraction? First substance is called angiotensin 2. Okay, angiotensin 2 will cause mesangial cell contraction, as well as endothelin. Okay, endothelin. So these substances, angiotensin 2 and endothelin, will cause mesangial cell contraction. And substances which will cause mesangial cell relaxation are ANP. What is this ANP? Atrial natriuretic peptide. See, atrial natriuretic peptide is produced from the atria. Atrial natriuretic peptide, which is produced from atria. This atrial natriuretic peptide, which will cause mesangial cell relaxation, increases the GFR. And one more substance is nitric oxide. Okay, nitric oxide. Remember, for your entire life, nitric oxide is a relaxant. Nitric oxide is a vasodilator. Okay, so nitric oxide, A and B, will cause relaxation, that will cause increase in the GFR. Someone, Roy, you are saying something called CAMP, but I just want you to know nitric oxide acts by which mechanism? Which secondary messenger? CAMP or CGMP? Nitric oxide acts by which secondary messenger? CGMP. Okay, CGMP, not CAMP. It's a CGMP. Very important point. Nitric oxide uses CGMP as a secondary messenger, not CAMP. Okay, just go through your notes, check one more time. Now, after discussing this, let's talk a few more conditions where GFR is regulated. Now, let's talk about a concept called as regulation of GFR. Regulation of glomerular filtration rate. Now, how to understand this concept, sir? See, your kidneys all the time have one function. They want to maintain the glomerular filtration rate. They have to filter the blood. They have to take out the waste products from your blood. That's the only thing which kidneys knows. Okay. For example, imagine there was this one condition where the person's GFR is falling down, okay, due to some reason. I will explain you what is that reason. But if GFR is falling down, normal GFR is 125 ml per minute. If the GFR is falling down, your kidneys have an ability to bring back the GFR to normal. If GFR is going down, they have a capability to again bring back the GFR to 125. Okay. Now, if GFR is increasing, for example, imagine that the patient's GFR is going 150, 160, 170. Now, if GFR is increasing, your kidneys are having a capability to bring down the GFR to normal. So that's called as regulation of GFR. Now, how that regulation will happen, we will see. Okay. Now, let's see guys here. This is afferent arteriole. Okay, not afferent arteriole. Let me first draw. Let me draw. See, right now I am showing afferent arteriole from this side. This is afferent arteriole. Please make a note. I am showing afferent arteriole from this side. Here is the efferent arteriole. Okay, blood is coming like this and blood is leaving like this. Okay. Now, guys, we just need to make a little change with the camera adjustments. Just let's take a break of 1 minute. Okay. Let's continue, guys. Now what we are discussing here is the afferent arteriole, which is bringing the blood to the nephron, and here is the efferent arteriole. Now see, here is the proximal, here is the Bowman's capsule. Now I am showing you, this is the first part of nephron, which is called as a proximal convoluted tubule. Now after PCT, we are having descending limb of loop of Henle. This is the hairpin turn, and ascending limb of loop of Henle. Here is the ascending limb of loop of Henle. After this, see, this is the distal convoluted tubule. Distal convoluted tubule, proximal convoluted tubule. This is the loop of Henle. Now, important points. What are the important points here in the topic of regulation of GFR is that, see, the smooth muscle cells of afferent arteriole, the smooth muscle cells of afferent arteriole, they are modified. Some smooth muscle cells of afferent arteriole are modified into special type of cells called as juxtaglomerular cells. Okay, so juxta means side to the glomerulus. Here is the glomerulus. Okay, here is the glomerulus. So juxtaglomerular cells means these. They are nothing but modified smooth muscle cells of afferent arteriole. And one more type of cells, specialized cells, which are present on the distal convoluted tubule. Now what are these cells called as? These cells are called as macula densa. So important point is, macula densa is present where? Sir, macula densa is present in the early part of distal convoluted tubule. Now where is this juxtaglomerular cells present? Juxtaglomerular cells present on the afferent arteriole, which are modified smooth muscle cells. Now along with them, there are few more cells which are not having, whose function is not properly known. These are the extraglomerular mesangial cells, extraglomerular mesangial cells. Now important point, what I am trying to put into your mind here. See, a combination of these three structures, juxtaglomerular cells, extraglomerular mesangial cells, along with macula densa. Now all of them, these three of them, they are forming a structure called as JG apparatus, juxtaglomerular apparatus. Now what exactly is this juxtaglomerular apparatus and what it is consisting of, why it is important? See, juxtaglomerular apparatus, it's made up of three components. I have already taught you what are the three components of juxtaglomerular apparatus. The three components are JG cells, the second one is macula densa, and extraglomerular mesangial cells. Now these extraglomerular mesangial cells are also known as Polkesin cells. Polkesin cells are also called as extraglomerular mesangial cells. Okay. Now, see, important concept is they will maintain the GFR. Okay, this JG apparatus, JG apparatus maintains or regulate GFR. How, sir? How? Now we will see how it is regulating the GFR. Now let's take a condition where the person's glomerular filtration rate, the glomerular filtration rate is increasing. Instead of 125, it is getting more and more. Okay, hyperfiltration is happening. If hyperfiltration is happening, that will cause damage. If more and more filtration is happening into the nephrons, there is more workload on the nephrons, that will cause damage to the nephrons and kidneys. It will cause glomerulosclerosis. This is something bad and it should not happen. GFR should be something in a normal range. Normal average is 125 ml per minute. But if there is hyperfiltration, what your kidney should do? It should have to bring the GFR to normal. How it will happen is, see, if GFR is increased, more filtration. Okay, more filtration is happening. So more filtration, if it's happening, means what happened to the sodium chloride? If more and more fluid filtering means, in that fluid there will be definitely more NaCl, sodium chloride, is reaching where? More sodium chloride is reaching the distal convoluted tubule. Okay, see, more is getting filtered. If more is getting filtered means more fluid is there in the Bowman's capsule. More fluid is going into the loop of Henle. More fluid is going into the DCT. In more fluid, there will be more amount of NaCl. Okay. So, more NaCl is going to DCT. On the DCT, we have already discussed in the early part of distal convoluted tubule, there is a structure called as macula densa. Okay, there is a structure called as macula densa is there. Now, this macula densa, it's all the time sensing sodium chloride levels. It knows only one thing. Macula densa, it knows only one thing. It all the time senses sodium chloride levels. Okay, now if more sodium chloride, if it is seeing more sodium chloride means it will understand more sodium chloride is coming means GFR is increased. Okay, macula densa is sensitive to, macula densa, very important point, sensitive to sodium chloride. Now what this DCT will do, what this macula densa will do, now macula densa, okay, it's producing substance called as adenosine. Okay, it's producing now adenosine. Now just answer, adenosine, what it will do? Adenosine is a afferent arteriolar vasoconstrictor or vasodilator. I have already taught you, adenosine will cause afferent arteriolar constriction. Okay, afferent arteriolar constriction, afferent arteriolar constriction. So afferent arteriolar is constricted. When afferent arteriolar, if it is constricted, what happened to the amount of blood coming to the glomerular capillaries? Reduced. So automatically what happened to GFR? Reduced. So afferent arteriolar constriction will decrease the GFR. So see here guys, if GFR is increased, okay, because of any pathological reasons, if GFR is increased, automatically GFR is going to bring down to normal. Who is doing that? Who is doing that? Macula densa. Okay, so macula densa, it's what it is doing? It is giving feedback. Macula densa is present on the tubule, distal convoluted tubule. So tubule is communicating back to glomerulus. Okay, so this is called as tubuloglomerular feedback. Okay, sorry with my handwriting. So the concept is called as tubuloglomerular feedback, which is causing constriction of the afferent arteriole, which will decrease the GFR, bringing back the GFR to normal. This is the regulation of GFR. Okay, now let's take one more scenario. Now in the second scenario, let's discuss about GFR going down. GFR is decreasing. Okay, GFR is decreasing. Now what might be the reason GFR is decreasing? See, one reason can be the person is having a road traffic accident. Imagine the person is going on a motorcycle, he had a road traffic accident. Then whenever he had a road traffic accident, definitely he is going to have hemorrhage. Okay, blood is losing from his body. So what happened to his blood volumes? Blood volumes are going to go down. If blood volumes are going to go down, automatically the amount of blood, the renal blood flow, the amount of blood going to the kidneys will also automatically decrease. If less blood is going, less filtration will happen. So GFR is going down. I have given you an example. GFR is going down. But kidneys, they can maintain the GFR. They can regulate the GFR. Okay, how? See, when GFR is decreased, okay, when GFR is decreased, so what happened to the amount of sodium chloride going to the DCT? Less blood is going to the kidneys, glomerular filtration rate is decreased. So automatically the amount of sodium chloride reaching the macula densa, the amount of sodium chloride reaching the macula densa is also decreased. Now see, macula densa. Okay. Now macula densa, what it will do? If it is receiving less amount of sodium chloride, it will understand. If more amount of sodium chloride is coming means it will understand that okay, GFR is increased. If less amount of sodium chloride is coming to the macula densa, it will understand in such a way, okay, GFR is falling down. Now what it have to do? Now macula densa will activate juxtaglomerular cells, juxtaglomerular cells. Now JG cells got activated. Now macula densa is activating, giving signals to the juxtaglomerular cells. Now these juxtaglomerular cells, what they will do? Now these juxtaglomerular cells, now they will release renin. Now we all know when renin is there, automatically RAS pathway, okay, RAS pathway is activated, renin angiotensin aldosterone system. We all know when RAS pathway is activated, what will happen at the end of the day? Angiotensin 2 is there. Okay, in the RAS pathway, angiotensin 2 is produced. Now what this angiotensin 2 will do? vasoconstriction. Sorry guys. Now this angiotensin 2 will cause vasoconstriction. Okay, just give me 1 minute. Okay, vasoconstriction of efferent arterioles. Now angiotensin 2 already I have discussed with you. It will cause vasoconstriction of efferent arterioles. When the efferent arteriole is constricted, what happened to GFR? GFR is increased. GFR will come back to normal. So if any condition, if GFR is going down, your macula densa along with the juxtaglomerular cells or the juxtaglomerular apparatus will bringing back the GFR to normal. Okay, so this is what you need to know. So tubuloglomerular feedback, again here also the macula densa is activating the JG cells. Now this is giving feedback to the glomerulus that efferent arteriole need to be constricted to increase the GFR. So again tubuloglomerular feedback. So if you want to know two important MCQs, tubuloglomerular feedback is given by which structure? Macula densa. Macula densa is present where? Macula densa is present in the early part of DCT. Macula densa is sensitive to which concentration? Sodium chloride concentration. Okay, so this is what you need to know. After this, let's talk of one more scenario where GFR will be affected. Now I am asking you one question. See, high protein diet. High protein diet, how it will affect GFR? How GFR is affected? What happened to GFR? If you take high protein diet, what happened to GFR? Will GFR be more? Will GFR be increased or will the GFR be decreased? That's the question. What happened to GFR? Try to answer it, guys. I'm giving you 1 minute. Think and say, there is high protein diet. What happened to GFR? Just think logically and tell me. To know this concept, you need to know certain basic things. Guys, I am showing you afferent arteriole, efferent arteriole. Okay, see, normally the basic physiology is that amino acids are freely filtered or not. I have already taught you glucose, amino acids, everything are freely filtered. Even glucose, amino acids, everything is freely filtered. But I have already taught you, as these substances are high threshold substances, very important substances, all the amino acids, whatever are coming into the PCT, the first part of nephron, proximal convoluted tubule, all the substances, amino acids will be reabsorbed. 100% reabsorption will happen. But remember, this amino acid reabsorption occurs along with the sodium. So sodium and amino acids, they are transported together. The basic physiology. All the time, amino acids are reabsorbed along with sodium. Without sodium, amino acids are not reabsorbed. They cannot be reabsorbed. So now tell me, based on this concept, what happens if you eat so much amount of proteins? If you eat so much amount of meat, what will happen? Think logically and tell me, guys. So, see here. Whenever you eat protein rich food, so digestion will happen. So more protein means more amino acids. More amino acids are produced. So if more amino acids are produced means more amino acids are filtered. If more amino acids are filtered means to absorb all that amino acids, okay, more sodium is reabsorbed. Okay, so to reabsorb all these amino acids, more and more sodium is reabsorbed in the PCT. So if more sodium is getting reabsorbed in the PCT, what happened to amount of sodium reaching the macula densa? What happened to the amount of, see, more and more sodium is getting reabsorbed in the process of reabsorbing amino acids. More sodium is being reabsorbed. So what happened to the amount of sodium reaching the DCT? Here is the DCT. Okay, here is the macula densa. If more sodium is being reabsorbed in the PCT, less sodium will reach DCT or macula densa. So now macula densa is saying, oh my god, less sodium is coming. Whenever less sodium is coming to macula densa, what it will do? Immediately, whenever less sodium is coming to macula densa will produce, see, macula densa. It will release or it will activate juxtaglomerular cells. Now these juxtaglomerular cells will activate RAS pathway. Now whenever RAS pathway is activated, we all know that efferent arterioles are constricted. Efferent arterioles are constricted. Efferent arteriolar constriction will increase the GFR. GFR is increased. GFR of the person who have consumed lot of amino acids, who have consumed lot of protein, GFR increases. So in a single way we can put like this: if a person is taking a high protein diet, the person's GFR, glomerular filtration rate, will be increased. Why? Because in the process of reabsorption of amino acids, more sodium is getting reabsorbed in the PCT, less amount of sodium is reaching the macula densa. So macula densa, what it will do? Immediately activate the JG cells, RAS pathway is activated, efferent arteriolar constriction, efferent arteriolar constriction will happen. So GFR initially increases. Okay? Okay guys, is it clear? What and all I have discussed, is it clear guys to you? So all things about the GFR. Okay, so how GFR will be affected, the tubulo-glomerular feedback, the regulation of GFR, how GFR is affected in the high protein diet, how GFR is affected in afferent arteriolar constriction and dilation, how GFR is affected in efferent arteriolar constriction and dilation, how GFR is affected in mesangial cell contraction and mesangial cell relaxation. All these points about GFR, the calculation of GFR, the substances used for GFR, everything we have completed. Okay, now after this, let's talk about proximal convoluted tubule, PCT, the first part of nephron, that's the proximal convoluted tubule. Okay, so everyone knows here is the Bowman's capsule. Now after the Bowman's capsule, we are having a segment of nephron which is called as PCT. Okay, let me show you here. This region is the proximal convoluted tubule. Now, what are the important points which you need to know? The 4 important points are there regarding the proximal convoluted tubule. What are the 4 important points? The first point is here. See, here you will be having epithelial cells or not? Yes, proximal convoluted tubule is also having epithelial cells. Okay. Now, some characteristic feature of this proximal convoluted tubule is that these epithelial cells, they are having this brush border. Okay, this brush border is not there in the other parts of nephron. Proximal convoluted tubule is something which is having this brush border. Now why it is having brush border? It increases the surface area. So PCT have brush border. Okay, why? It increases surface area. It increases the surface area. See, very important point. PCT is the region where 100% of amino acids will reabsorb, 100% of glucose will reabsorb, almost 70% of sodium, 70% of chlorine will be reabsorbed. So most of the substances are reabsorbed in the PCT only. So if you want to reabsorb more substances, the surface area needs to be also more. Okay, surface area of the PCT should be more. So how you can increase the surface area? By creating a brush border. So PCT epithelial cells have brush border. Now PCT, I have taught you, most of the substances are reabsorbed. So what is the most active segment of the nephron? The most active segment of a nephron is PCT. So highly metabolically active The most metabolically active segment in a nephron is PCT. It's having brush border, we have already discussed. The third important point is the maximum reabsorption. Maximum reabsorption in the nephron. See, when compared to DCT, collecting ducts, collecting tubules, or the descending limb of loop of Henle, ascending limb of loop of Henle, most of the substances are maximally reabsorbed in the PCT. So maximum reabsorption capacity is there for PCT. And as it's working more and more, it demands more oxygen, highly metabolically active segment. For example, in the conditions of hypoxia. In hypoxic conditions, which part of nephron is highly susceptible? Its demand of oxygen is very much. It's working more and more. It needs more oxygen. So highly susceptible for hypoxia is PCT. Highly susceptible. So highly susceptible for hypoxia. Okay. So highly susceptible segment for hypoxia is a PCT. Okay. These are the very important points which you need to know. Brush border is PCT. Active segment is PCT. Susceptible for hypoxia is PCT. Now after this, let's talk about substances reabsorbed in PCT. What are the substances which are reabsorbed in the proximal convoluted tubule? Okay, substances reabsorbed in the proximal convoluted tubule. Now you need to know these things. Just tell me, what are the substances? You just think yourself. Which substances are reabsorbed in the PCT? I have already taught you. 100% of glucose. Okay, 100% of amino acids. 100% of glucose, 100% of amino acids, and almost 70% of water is also reabsorbed in the PCT. 70% of water is reabsorbed, 70% of sodium, and 70% of chloride. 70% of sodium, 70% of chloride, and almost 70% of calcium is also reabsorbed in the PCT. Now along with that, almost 70% of urea and potassium are also reabsorbed. 80% of PO4 minus phosphates and 80% of bicarbonates are also reabsorbed in the PCT. So remember one important point: 100% of glucose, 100% of glucose, 100% of amino acid, 70% of water, 70% of sodium, 70% of chlorine, 70% of urea and potassium, 80% of phosphates, and 80% of bicarbonates are reabsorbed in the PCT, which means most of the substances are reabsorbed in the PCT itself. Okay. Now, after this, the important concept which you need to know is why there is 70% water reabsorption is happening in the PCT. See here guys, I am showing you. This is the PCT. These are the PCT epithelial cells. Okay. See here. This is a transporter which is present here. Okay. On the luminal side, luminal surface of the PCT epithelial cells, there are transporters. Now, normally, I have already taught you, sodium reabsorption will happen along with glucose. So glucose is reabsorbed along with the sodium. Glucose as well as amino acids will be reabsorbed along with the sodium. So what I am trying to put into your mind is sodium reabsorption is happening, along with sodium reabsorption, glucose reabsorption is happening, amino acid reabsorption is happening. But important point here is, forget about everything. Important point is how much sodium is getting reabsorbed in the PCT. Okay, how much sodium is getting reabsorbed? Sir, almost 70% of sodium is getting reabsorbed, and 70% of chlorine is also getting reabsorbed. Okay, 70% of sodium and 70% of chlorine. Now, what is NaCl? Sodium chloride. It's a salt, right? Sodium chloride. Now, from our basic understanding, we have already discussed, wherever sodium goes, water will follow. Okay, wherever the sodium goes, water will follow in the same direction, right? So sodium 70% is getting reabsorbed. So automatically, how much water will be reabsorbed? 70% water is getting reabsorbed. Okay, just along with sodium, 70% water reabsorption is also happening in the PCT. Now, this type of water reabsorption in PCT, is it under the control of any hormone? Is it the water reabsorption in PCT, is it under control of any hormone? I am asking you. Is it under control of any hormone? PCT water reabsorption? No, there is no hormone involved. Simply sodium for water reabsorb. Sodium reabsorb, water reabsorb. So this type of reabsorption is called as obligatory. Okay, obligatory water reabsorption. Okay, so now my question is, obligatory water reabsorption is happening in which part of nephron? PCT, sir. Okay, why? Because there is one more type of water reabsorption which is called as facultative water reabsorption. Facultative water reabsorption is under the control of hormones. Okay, see, whenever there is antidiuretic hormone, at the end of the lecture we will discuss, whenever there is antidiuretic hormone, that antidiuretic hormone will help in reabsorption of water in the collecting tubules and collecting ducts. That water reabsorption is under the control of hormones, that is facultative with the help of hormones. But right now here in PCT there is no need of any hormones for water reabsorption. Okay, so this is obligatory water reabsorption. Okay, now after this, one more important concept I want you to know here. Sir, here is the afferent arteriole. Let me show you with the red color. See, this is the afferent arteriole which is bringing the blood to the nephron. Okay, here is the glomerular capillaries. Here is the efferent arteriole, afferent arteriole, efferent arteriole. Now blood is coming like this, the plasma is coming like this. Plasma is getting filtered here. The concept is, what is the normal osmolarity of the plasma? What is the normal osmolarity of the plasma? See, what is this osmolarity, sir? How to understand the concept of osmolarity? Very simple. Imagine that there was this one beaker which is with the water. Okay, beaker with the water. Now I am just keeping here pure water without any contaminants, without any solutes. Okay, now what is the osmolarity of this pure water? The osmolarity of a pure water is 0. It's a pure, there is no contamination, there is no solute, so osmolarity is 0. Now imagine I am just trying to put salt into it. I am putting salt into it. Okay, I am putting salt into it here. Now when I am keeping salt here, what happened to osmolarity? What happened to osmolarity here? Sir, the concentration is increasing, right? So osmolarity is also increasing. If I put little salt, the osmolarity will become 10 milliosmoles. If I put more salt, it will become 20 milliosmoles. If I put more salt, it will become 100 milliosmoles. Something like that. So osmolarity is dependent on what? Sir, osmolarity is dependent on the ions or solutes. More solutes, more osmolarity. My question is, your blood which is running in your blood vessels, is it a pure water? Is it a pure fluid? Definitely not. It is having sodium, potassium, magnesium, calcium, plasma proteins are there, clotting factors are there. So there are so many solutes into it. There are so many ions are there. Now because of the presence of so many solutes, your blood is also having certain concentration. So how much concentration, sir? Concentration is measured in the units of osmolarity. How much osmolarity? 300 milliosmoles. Your blood is having an osmolarity of, okay, how much? See, this course is you don't need to pay any course fee. Okay, these are free lectures. You can watch it on YouTube. Every week we will be coming live. There is no need to pay anything. Okay, just like this, will be coming to live and you can watch regular series. Okay, already we have done an introductory video in last week. Now this week we'll be doing 2 more sessions and we'll complete the entire renal physiology. This course is absolutely free. You don't need to pay any single rupee. Okay, now osmolarity is 0. Okay, normal blood osmolarity is 300 milliosmoles. Now my question is, plasma is getting filtered. Plasma along with sodium, potassium, magnesium, calcium, everything. Now, plasma is getting filtered or not? Yes, it's getting filtered, sir. So, what is the osmolarity of fluid in Bowman's capsule? Same. 300 milliosmoles. Same plasma is getting filtered. Now, my question is, as the fluid is coming down, as this filtrate, as this urinary ultrafiltrate, okay, as this primary urine, this is a primary urine, right? Now, as this urine is moving down to the PCT, at the end of PCT, what is the osmolarity? Now, imagine from here we are starting the loop of Henle. Okay, we have started with the loop of Henle. My question is, what is the osmolarity here? Sodium is getting reabsorbed. We are taking out the solutes. Now, what happened to the osmolarity? Osmolarity is same, osmolarity is increased, or osmolarity is decreased? The osmolarity is same at the end of, at the end or the starting point, at the end of PCT or in the loop of Henle, in the starting point of loop of Henle, descending limb of loop of Henle. Okay. Now, osmolarity is same. Okay. Why same, sir? Okay. The fluid is isoosmolar. Isoosmolar means what? Isotonic. Same concentration with the blood plasma. Blood plasma is 300 milliosmoles. Here also 300 milliosmoles. Now question is, why the fluid is isoosmolar? It's because, see, please concentrate. How much amount of solute, the major solute, how much amount of solute is being reabsorbed? Sir, 70% of the solute is being reabsorbed. But along with the solute, same concentration of water is also getting reabsorbed. So 70% sodium is reabsorbed. Same 70% of water is reabsorbed. So solute, how much, like whatever the solutes are being reabsorbed, same proportion of water is also being reabsorbed. So there is no change. Imagine, think like this. If only solutes are reabsorbed, then the osmolarity will be decreased. If only solutes are reabsorbed. But right now, same amount of solute, same amount of solvent. Solvent is water. So same as the reabsorption is happening in the same proportion, there is no change in the osmolarity at the end of proximal convoluted tubule. Okay. Now, after this, let's talk some pathocorrelation. Okay. Pathocorrelation. Now, those who are studying your second year pathology, okay, those who are studying second, third, fourth year, now you just tell me, sir, there was this one condition where, okay, here I am showing you the Bowman's capsule. Here is the proximal convoluted tubule. Now, here what's supposed to be happening? I have already discussed with you. Water reabsorption should be happening. Okay, water is supposed to be reabsorbed. Sodium is supposed to be reabsorbed. Calcium is supposed to be reabsorbed. Okay, and phosphates are supposed to be reabsorbed. Bicarbonates are supposed to be reabsorbed. Now, important point is, this reabsorption is happening along with the help of certain transporters. There was this one pathological condition, there is one pathological disease where PCT is not functioning. The PCT is not functioning, or the transporters in the PCT are not functioning. So that will cause natriuresis, sodium is lost. Glucose reabsorption is not happening. So glucose urea, amino acid urea, phosphaturia, calciuria is happening. So because of the non-functional PCT transporters, okay, because of the non-functional PCT transporters, like amino acid urea, glucose urea, phosphaturia is happening. Can you name me what is that condition? Anyone? It starts with the letter F. and Fanconi syndrome. Now, very important point. So, what exactly is Fanconi syndrome? Fanconi syndrome is a pathological condition where PCT is affected. Where PCT is affected. Okay, that's a Fanconi syndrome. Now, let's talk about some pharmacorrelation. Okay, pharmacorrelation. Now, see, have you ever studied about a condition called as diabetes mellitus? There was this one disease called as diabetes mellitus. Now, in diabetes mellitus, what is the main problem? In diabetes mellitus, sir, the problem is high levels of glucose in the blood. Okay, high levels of glucose in the blood. So, how to treat diabetes mellitus? The treatment is by decreasing the blood levels of glucose. Now, how we can do that? By understanding the concept of proximal convoluted tubule. How we can understand? How we can treat this condition? See, I am showing you right now. This is the proximal convoluted tubule. I have taught you that 100% of glucose reabsorption and 100% of amino this is glucose and 100% of amino acid reabsorption will happen in the PCT. PCT. This is PCT. Now, here is one transporter. This is one transporter. Now, this transporter, what it is doing? It is reabsorbing the glucose and it also reabsorbs the sodium. Along with the sodium, glucose is reabsorbed. Okay, along with sodium, glucose is reabsorbed with the help of this one transporter. So this transporter is called as SGLT. Okay, SGLT type 2. So what is this SGLT? Sodium glucose co-transporter type 2. So SGLT type 2 is present in which part of the body? SGLT is a sodium glucose co-transporter which is present in the proximal convoluted tubules, no doubt. Now what it is doing? It is reabsorbing the glucose along with the sodium. Now the concept is that if you can inhibit this transporter, what will happen? Glucose is not going to be reabsorbed. Glucose is going to lost in the urine. The glucose which was supposed to be reabsorbed is right now not getting reabsorbed. It is losing in the urine, causing glucosuria. But is this good or bad? In this patient, this is good. The patient is suffering with the high levels of glucose in his blood. If you want to decrease his glucose levels in his blood, you can inhibit this channel, sodium glucose co-transporter type 2. So glucose is lost in the urine. So blood levels of glucose will come down. Okay, can you name me SGLT type 2 inhibitors? Anyone? Anyone who can tell me sodium glucose transporter inhibitors? Anyone? Anyone? They will start with the letter C, D, E and ends with the name gliflozins. Gliflozins. Have you ever heard about these drugs? Gliflozins. Cana, gliflozin, DAPA, gliflozin, EMPA, gliflozin. So these are gliflozin group of drugs. Canagliflozin, dapagliflozin, empagliflozin. These drugs will inhibit the sodium glucose co-transporter type 2 so that glucose is lost in the urine. But important problem, see, you are treating the diabetes. Okay, so gliflozin group of drugs are used to treat the diabetes. There is no doubt. But the same group of drugs are increasing the urinary glucose, the amount of glucose going through the urinary tract or the amount of glucose which is going into the urinary bladder is more. Right now, more and more glucose is present in the urine. Now, will this glucose attract the bacteria or not? Yes. So, using these drugs, glucoseurics or glycoseurics means glucose is lost in the urine. So, these drugs which I have taught you, these are called as glycoseurics. Now, they are increasing the excretion of glucose. So, what they will do as a side effect? They will cause urinary tract infections. The most common side effect by using this kind of gliflozin drugs or glycoseurics is urinary tract infections, UTI. Okay, urinary tract infections. Okay, guys, you have any doubt? If you have any doubt, you can ask me. Today I am having very bad runny nose. Now, I will ask you certain questions which are actually a topic of general physiology, but let me see how many of you can really answer. If you are really good, just try to answer it. Okay? See, this is PCT. I have already taught you sodium reabsorption will happen along with glucose reabsorption. So glucose is getting reabsorbed. Okay, so glucose is getting reabsorbed. Now my question is, this glucose reabsorption is an active process or it's a passive process? First question, the glucose reabsorption, or even it's the same for amino acid also. Now my question is, glucose reabsorption in the PCT, amino acid reabsorption in the PCT, it's happening actively or passively? First question, it's happening active process or passive process? It's active. It's an active process. Guys, please be attentive. You just try to interact. I'm here. I will be like, no, I'm just checking. It's an active process. What does I mean by active? See, active process means ATP is utilized, ATP is involved, energy is involved in reabsorption. Energy is involved. Now you can ask me, sir, where energy is involved? Where energy is involved? How energy is involved in this process? Normally, remember, on these basolateral membranes, okay, on these basolateral membranes, there are the special transporters which are present on the PCT epithelial cells. I'm just talking right now about one transporter. The transporter name is called as sodium, potassium, ATPase. Now, what this sodium, potassium, ATPase is doing? Do you know? Now, the sodium, potassium, ATPase, it will throw 3 sodium ions out of the cell. It will bring 2 potassium ions into the cell. Constantly, 24/7, every day. What's happening? On the PCT epithelial cells, there are these transporters called as sodium, potassium, ATPases. These sodium, potassium, ATPases, what they are doing? They are throwing the sodium out of the cell, out of the cell. So, what's happening to intracellular sodium concentration? Now, I'm asking you, what happened to intracellular sodium concentration? What happened to sodium? Intracellular sodium concentration. So, inside the cell, sodium concentration is kept low. See guys, sodium, potassium, ATPase. Now this transporter, see this transporter by using ATP, it is creating less sodium states inside the cell. This less sodium states inside the cell is achieved by sodium, potassium, ATPase. Here ATP is getting involved. Remember, first point. Now, inside the cell, there is less amount of sodium. Here, there is more amount of sodium. More amount of sodium is getting filtered, right? Okay, more amount of sodium is getting filtered. So, the sodium concentration in the lumen is more. The sodium concentration in the cell is less. Okay. So, what is happening? So, sodium is getting reabsorbed because here there is more sodium concentration. Inside the cell, there is less sodium concentration. So, sodium is moving from high concentration to low concentration. So, sodium is only getting reabsorbed because of the concentration gradient. This concentration gradient is created by utilizing the ATP. ATP is involved. Okay, so whenever sodium moves, along with the sodium, even glucose is getting into the cell. So, it's an active process or passive process? Definitely active process. The sodium is reabsorbed with the help of the sodium, potassium, ATPase, indirectly. So, whenever sodium is moving into the cell, along with the sodium, even glucose is also reabsorbed. Let me put it in a different way so that you can easily understand. Okay, this is just an example. I am asking you one question. See, imagine you have a ball, cricket ball, okay, cricket ball in your hand. Now, when you want to just throw up, you need to give energy or no energy is needed. Just tell me. You just imagine you have a cricket ball in your hand. Now, if you want to throw up, you have to give energy. So, you have to give energy to throw ball up against the gravity. Now, when ball is again coming down, when the ball is coming back down, this falling ball will release the energy. The falling ball will release energy. When something is coming from high to low, it is releasing the energy. If you want to know, whether it's releasing the energy or not, you just go and stand below the ball. You just see like this. When the ball hits you, you will understand that the energy is released, okay, in the form of kinetic energy. Okay, so what I'm saying is, if you want to throw ball up, you need to give energy, but the same ball, when it's again falling back, it will release the energy. So in anything which is coming from high to low, okay, freely falling, it releases the energy. So how to understand that concept here, how to apply that concept here? See here, sodium, it is coming from high concentration to low concentration. When sodium is coming from, just give me 1 minute guys. So when sodium okay, so when sodium, it's moving from high concentration to low concentration. Now what it will do? It will release a lot of energy. With that energy, now glucose is reabsorbed into the cell. Okay, so it's an example of active process. But directly energy is not utilized here. Direct energy involvement is not there. Indirect energy involvement. So it's an example of secondary active transport. Okay, so sodium glucose reabsorption in PCT is an example of, it's an example of secondary active transport. Okay, if you have any doubts, you can ask me. I'm just checking out your comments. If you have any doubts, you can ask me, guys. It's an indirect energy involvement. Okay. So sodium glucose reabsorption, sodium amino acid reabsorption is an example of secondary active transport. Now, after this, you just try to answer what exactly is filtered load. So what exactly is filtered load of glucose? Guys, can you tell me what exactly is filtered load of glucose? To understand the concept of filtered load of glucose, many students don't know what exactly is filtered load of glucose or how to calculate the filtered load of glucose. It's very simple. Normally, I am asking you one question. See, what is the plasma glucose concentration in you and me? In a normal person, okay, randomly you come to me, if you take my plasma out, if you take my blood out, and if you check the blood glucose concentration, how much amount of glucose will be there in the blood? Normally, random. Sir, 100 milligrams. 100 milligrams per deciliter. Okay, 100 milligrams of glucose is there in 1 deciliter. Deciliters means how much? 100 ml blood. So in 100 ml blood, 100 milligrams of glucose is there in a normal person, in you and me. So which means 1 milligram of glucose is present in 1 ml of blood. Very simple. 1 milligram of glucose is present in 1 ml of blood. Very simple. Now, what is filtered load of glucose? Filtered load of glucose means how much glucose is filtered in 1 minute. So see, here is the Bowman's capsule, here is your glomerular capillary. So first of all, what is the glomerular filtration rate? Just tell me. Sir, GFR, glomerular filtration rate, is 125 ml. Sir, here 125 ml of fluid is getting filtered, 125 ml of plasma is getting filtered. See, I have already taught you, in you and me, in a healthy person, in 1 ml of plasma, there is 1 milligram of glucose. If 125 ml is coming into the Bowman's capsule, if 125 ml is filtered, how much glucose is getting into the Bowman's capsule, or how much glucose is getting filtered? 125 milligrams. So normally filtered load in you and me is 125 milligrams per minute. So every minute in both the kidneys, in all the nephrons, 3 million nephrons, 125 milligrams of glucose is filtered. So this is the filtered load. So the formula for filtered load, if you want to know, the formula for filtered load is GFR into plasma concentration. GFR into plasma concentration. For example, see, what is my GFR? Sir, GFR in my body is 125 ml. Okay, 125 ml. What is my plasma concentration of glucose? Sir, the plasma concentration of glucose is 1 milligram per 1 ml. So in a normal person like you and me, the filtered load is 125. See, 125 into 1, that is 125 milligram per minute is the filtered load. For example, imagine that there was this one person who is a diabetic, who is suffering with diabetes mellitus. Now in this person, diabetes mellitus person, now imagine that the GFR is constant. Even in a person who is having diabetes mellitus, let's assume that the GFR is normal. Okay, GFR is normal. Now, what happens to his blood levels of glucose? Diabetic is having high levels of glucose in his blood, high plasma concentration of glucose. The plasma concentration is 2 milligrams per ml. Now, if 2 milligrams per ml means so 125 into 2 milligrams per ml. So 125 into 2, how much? 125 into 2. How much it will become? Just try to answer now. Just tell me what is the filtered load. 125. GFR is constant. Now the plasma concentration is 2. How much it will come? It will become 250 or not? Yes, 250 milligrams per minute. So this is filtered load. So from this, can we say in a diabetic person, the filtered load, the amount of glucose getting filtered every minute is high. Okay, more and more glucose is getting filtered into his nephrons. Okay. Now, why I have discussed this with you? Okay. See, in a normal person, let me write it here. 3 important scenarios. In a normal person, what is the filtered load? The filtered load is 125 milligrams per minute. 125 milligrams per minute. Now, at this filtered load, can you see any glucose in the urine? In the urine, can you see any glucose? My question is, in a normal person like you and me, will there be any glucose in the urine or not? My question, will there be any glucose? No glucose, sir. In urine, there is no glucose present. Normally, there is no glucose. Why there is no glucose? Because our nephrons are absolutely normal. Healthy nephrons are there. So, all the glucose, whatever is getting filtered, all the glucose will be reabsorbed in the PCT itself. 100% of the glucose will be reabsorbed in the PCT itself. So, there is no glucosuria. But imagine the second scenario. The second scenario is the plasma glucose concentration. The word is important. The plasma glucose concentration is 200 milligrams per deciliter. 200 milligrams per deciliter is, this person is diabetic. Okay, this person is diabetic. He's having so much amount of glucose in his plasma. So much amount of glucose is in blood. Now, what happened to filtered load? Now, tell me, what happened to filtered load? So, filtered load is going to be increased or not? Yes, sir. So, normal, what is the formula for filtered load? GFR into plasma concentration. GFR is 125. And what is the plasma concentration, sir? Plasma concentration here is 200 milligrams per deciliter. Per deciliter means, see, per deciliter means 100 ml. Okay, so we can say 200 milligrams of glucose is present in 100 ml. So every ml have how many milligrams? 2 milligrams. So here his filtered load in a diabetic person, the filtered load is 250 milligrams per minute. So what I am saying is, if a person is having high levels of glucose in his blood, automatically his filtered load is also going to be increased. Normal person's filtered load is how much? Normal person's filtered load is 125 milligrams. But a diabetic person's filtered load of glucose is 250 milligrams. Now my question, see, I am showing you Bowman's capsule. Here is the PCT. Now, how much is getting filtered here? How much is the filter load? The filter load is 250 milligrams per minute. Okay, I'm not talking about one nephron, in all the nephrons, all the kidneys. Okay, in both the kidneys. Now, normal healthy kidneys, healthy nephrons, they have a capability to manage a filter load of 125 normal filtered load of glucose. Normal filtered load of glucose is 125. But whenever you increase the plasma concentration of glucose, plasma glucose concentration to 200 milligrams, what happens? More glucose is getting filtered. Now, can these nephrons, can they reabsorb all the glucose? If there is lots and lots of glucose here, now the nephrons are not having such a capacity. Okay, not all the nephrons. There are some nephrons. Out of 3 million nephrons, a few nephrons, for example, okay, at 10,000 nephrons or 20,000 nephrons, they are not having a capability to reabsorb this much amount of filter load. So now what will happen? Now some glucose will start to leak out. So glucose is coming in the urine. Glucose is appearing in the urine. Now my question is, now at which concentration of plasma glucose? I have taught all the story for this one single question. What is the threshold for glucose? Urinary threshold for glucose. What is the urinary threshold for glucose? The urinary threshold for glucose is 200 milligrams per deciliter plasma glucose concentration. If you put this much amount of glucose in your blood, if you are having this much amount of glucose in your blood, now glucose will start to appear. Not entire glucose is coming. Now glucose is starting to leak out. Why? Because all the nephrons are not having a capability to reabsorb all this glucose. So some glucose will start to leak out. Okay. Now there is one more term called as transport maximum. Transport maximum. Now what is the concept of transport maximum? See, now I'm just telling you one more story. See, right now I'm not talking about the plasma concentration of glucose. I am not talking about the plasma concentration of glucose. Previously I have taught you, if you increase the plasma concentration of glucose to 200 milligrams per deciliter, glucose will start to appear in the urine. That value is called as renal threshold for glucose or urinary threshold for glucose. Now what I am saying, if the filter load in a normal person, what is the filter load, guys? In a normal person, the filter load is 125 milligrams. Okay, 125 milligrams of glucose is leaking in a normal person into the nephrons. Now, if you keep here 375 milligram, if you keep this much amount of glucose, direct question, if the filtered load, I'm not talking about the plasma, I'm talking about filtered load now. If the filtered load is 375 milligrams, which means so much glucose is getting filtered. This person is super diabetic, heavily diabetic, poorly controlled diabetes mellitus. So he is having lots and lots of glucose in his nephrons. Now, your nephrons are not designed to reabsorb this much amount of glucose. So what will happen? If you keep this much amount, there is no glucose reabsorption is going to happen further. Okay. Now after this value, there is no glucose reabsorption. All the glucose will start to appear in the urine. If you increase the filtered load, see, please concentrate on my terminology. If you increase the filtered load more than up to 375, okay, your nephrons can manage to reabsorb. But if you increase the filtered load more than 375 milligrams per minute, there is no further glucose reabsorption. All that further glucose will start to appear in the urine. So what is this? This is called as transport maximum. Why? Because all the transporters are saturated. Okay, all the transporters are working, so there are no more transporters available to reabsorb the glucose. So what is the transport maximum value? 375 milligrams. Okay, after 375 milligrams, is there is any reabsorption happening? Further reabsorption cannot happen. Okay, so what and all we have discussed, just simple 3 statements. What is the filtered load of glucose? The filtered load of glucose in a normal person is 125 milligrams per minute. What is the threshold, renal threshold for glucose? Renal threshold for glucose means for the first time glucose starts to appear in the urine. At which concentration? 200 milligrams plasma concentration. Now, what is transport maximum? Transport maximum means if you increase the filtered load more than 375 milligrams per minute, there is no further reabsorption happening. So what and all we have discussed, you just see it here in this one slide. Let me show you here. See here. Now this is glucose titration curve. Okay, normally. See, this blue color curve is a filtration curve. Everything is going to be easy. Don't worry. If you are not good with the graphs, don't worry. See, the blue color graph, what it is depicting. First of all, I'm on the x-axis. I'm talking about the plasma glucose concentration. Plasma glucose concentration on the x-axis. On the y-axis, I'm talking about here on the y-axis. I'm talking about the filtered load. Here is the filtered load. Okay, how much is getting filtered? That's the filtered load. Now, normally, see, I'm asking you one question. If you put more into the blood, if you increase the plasma concentration of glucose, what happened to filtration? More you put into the blood, more will be filtered. Simple, right? More plasma concentration, more will be filtered. So that's a basic thing. The more glucose you put into the plasma, more will be filtered. So that's the reason why this blue color graph, see, if plasma concentration of glucose is increasing, the blue color one, automatically filtration is also increasing, which means more and more is getting filtered into the Bowman's capsule. Okay, sir, understood. Now, what is this violet color line? This violet color line is talking about reabsorption. See, initially, I'm talking about the violet color line initially. So, initially, whatever is getting filtered, the blue color line, whatever is getting filtered, the same amount is reabsorbed. So, that's the reason why the blue color line and the violet color line, they are coinciding. They are like, they are exactly at the same point. Okay. So, whatever is getting filtered, that is getting reabsorbed in the physiological limits. Whatever is getting filtered, it is getting reabsorbed. Up till where? See, up till this point, at 200 plasma concentration, I have taught you. If the plasma glucose concentration, it is 200, what will happen? I have taught you. Now, for the first time, glucose will start to appear in urine. Glucose excretion is starting. So, see, the curve is like little bit moving away from the filtration curve. Why? Now, whatever is getting filtered, now everything is not getting reabsorbed. Now, little bit deviation. Now, why there is little bit deviation? Why? Because something is not getting reabsorbed. Something is leaking in the urine. So, that's the reason why I see at here, at this point, at 200 point, now the excretion curve has raised. The excretion curve. See, the green color curve is the excretion curve for glucose. Now, at 200 in the urine, glucose is raised, glucose excretion is started. So, what are the important points you need to know here? The 200 point is very much important, this point. Now, this is threshold for glucose. At 200 milligram plasma concentration, for the first time, the reabsorption curve got deviated from the filtered curve. Okay, from the filtered line, little deviation. Now, concentrate here, 400. Well, what is this 400? This is filtered load of glucose. Now, if the sorry, not 400, I should actually draw it here. See here, this is here less than 400, that is 375. Now, if the filtered load of glucose is 375 means the filtered load, I have already taught you, there is no further reabsorption at this much concentration. At this much concentration, what is happening to the reabsorption curve? Please concentrate. Now, reabsorption curve for the first time, it is getting flattened. Okay, it's not increasing, it's not going up. It is flattened, which means no further reabsorption is happening at 375 or after 375. Okay, after 375, there is no reabsorption. It's a flat line. Okay, everything is getting lost. Everything is getting lost. So at 375, please concentrate. At 375, see the urinary excretion curve is also taking a steep, which means whatever is not getting reabsorbed, that is getting excreted. So this is filtration, reabsorption and excretion. Filtration, reabsorption, excretion curves of glucose are simply called as glucose titration curves. Okay, it's a very simple point. After 375, there is no further reabsorption, or we can say one more thing. If you increase the plasma glucose concentration more than 200 milligrams per deciliter, glucose will start to appear in urine. Okay, guys, we have discussed a very important concept of this glucose titration curves. Okay, glucose titration curves. So with this, the proximal convoluted tubule. Okay, proximal convoluted tubule topic is completed. Now, in tomorrow's class, let's continue with the loop of Henle. Actually, I thought to complete the loop of Henle in this today's class because I'm having this runny nose. It's like little bit irritating to me. It will also affect the way of teaching. So tomorrow at 5:30, let's again meet with the topic of loop of Henle and let's try to complete the topic of renal physiology tomorrow. Hope the class is helpful. If you have any doubts, you can all the time message in the chat box. Okay, you can all the time message in the chat box and all the PPT will also be provided. Thank you. Close